Good morning. Such an honor to be here, and thank you for coming in this early on a kind of a nice Seattle morning. So I have no disclosures. I have a lot of slides, but I promise you I'm not going to go through all of them, but they're there for you if you want to kind of review it at some other time. My goal is to really talk about this new nomenclature, MASLD, talk about some of the risk factors, explore some of the non-invasive tests, because this has really taken us in a different direction. We're really not doing liver biopsies anymore. And most important, to really be able to identify those patients who are at a risk of MASH and advanced liver fibrosis. And I'll end with some evidence-based guidelines of how to manage these patients. So some basic definitions, which I know you all are familiar with. So hepatic steatosis is basically accumulation of fat in the hepatocytes, and you may identify them by doing imaging or by a biopsy. Whereas steatohepatitis is really a biopsy diagnosis. This is a histological diagnosis, and we should not really mix these two terms. So to call it steatohepatitis, you have to have three entities in a biopsy. You have to have steatosis, lobular inflammation, and hepatocyte degeneration, which is basically liver cells that are pretty much dying. And they may be some fibrosis, or they may not have fibrosis. So you have to have all of these three things to call it steatohepatitis. So I'm going to start off with a patient of mine. CJ is 48. I met him in 2019. He presented actually to his primary care doctor with right upper quadrant pain, and he had hypertension, hyperlipidemia, was only on losartan, and drinks socially. On exam, his BMI was high, his blood pressure was high, some central adiposity, otherwise a benign exam. And his primary care doctor actually obtained an ultrasound, which reported an echogenic liver. I'm sure you've seen all of these patients in your clinic. And his blood work, hemogram was fine. His LFTs, he did have an elevated ALT of 72, AST 73, alk phos and bilirubin was normal. So what is the cause of the abnormal LFTs? Could it be chronic hepatitis C, MASLD, alcohol use, or something else? Well, if you choose two, you're probably right, because that's the topic today. But it could very well be hepatitis C, which is still common. It could be alcohol, because we really haven't defined what social drinking that he's doing. And absolutely, it could be something else. But, so what would be our next step? Should we just repeat it in 4 weeks? This is a kind of a classic move. Everybody does that. I do it myself. We just feel that if we repeat it, maybe it'll be okay, but really that doesn't happen. Should we do some lifestyle advice? Absolutely. Refer to hepatology? Maybe. Calculate the FIB4 or proceed with a liver biopsy. And we're kind of going to go through all of these. So to take a step back, what is MASLD? So what we once knew as non-alcoholic fatty liver disease is now called metabolic dysfunction-associated steatotic liver disease, kind of pronounced as MASLD, like there's a Z in it. And it's really, I think this is so helpful because the definition is now very simple. So if you have steatosis, and if you have one of the cardiometabolic disorders, that is MASLD. So steatosis with one of them, that is a BMI of over 25. Actually, in some of the ethnic groups, especially among the Asians, the BMI is taken as 23. If you have either prediabetes or diabetes, if you have a triglyceride over 150, or if you have a low HDL, or if you have hypertension, if you have any one of these along with steatosis, that's enough to make a diagnosis of MASLD. So why this nomenclature change? Well, our understanding of fatty liver has really changed over the last 10 to 15 years. We now know it's a part of the metabolic syndrome. We know it's a multi-system disease. So for a long time, there's been this push to really change the nomenclature so it could be more inclusive, and we can really define it better based on its pathophysiology rather than having stigmatizing terms in the name of the disease itself. So initially, actually, it was called, from NAFLD, they made it MAFLD. So they changed it to metabolic dysfunction fatty liver disease. And then that was still not enough. And then eventually last year, it was changed to MASLD. So we took out the term fatty, and it was replaced by steatotic. The term alcoholic was removed, as it should be. I think we should stop using that term and really use alcohol use disorder or something similar. And more important, which I think was the most helpful, is this new category that was added called the MET-ALD. Basically, it is metabolic syndrome along with some moderate alcohol use. I mean, we all have these patients, right? They have metabolic syndrome, and they drink a little bit more alcohol than is permissible, but not enough to call them an alcohol use disorder. And we never used to know where to put them. So now we have this new category called MET-ALD, and we'll talk a little bit about that. It is a long name. It's especially very difficult when we are talking to patients. Even I still kind of tend to use the word fatty liver, but I think it's just getting used to it. So taking a step back about abnormal LFTs. So mildly elevated ALT and AST is quite common. And what's important to remember is the degree of ALT and AST elevation does not correlate with the severity of the disease. For example, if you have a patient with an ALT of AST of 40, 50, which is not very high, that does not mean they do not have steatohepatitis. That does not mean they do not have liver fibrosis. But however, what is important is if the AST-ALT ratio flips. So normally the ALT is higher than the AST, but when you have the AST that becomes higher than ALT, in the absence of alcohol especially, then you must consider advanced liver fibrosis. This was an interesting study which had close to 1,300 patients who had abnormal LFTs, but no previous diagnosis for the cause of these elevated LFTs, and they were followed for 2 years. And believe it or not, they had LFTs checked every month. I don't know how they agreed to that, but they did. And only 2.5% of the people with the abnormal LFTs actually had a specific diagnosis. But 40% had fatty liver on ultrasound. That's a lot more than we actually would have expected, but that's what they saw. And like I said, repeating an LFT after 1 month was really not necessary. And quite obvious, as we all know, the ALT and the alkaline phosphatase was what was associated with liver disease. So AST was not very helpful, and the GGT is also not very helpful. In fact, I don't even check GGT unless I'm trying to figure out, is it liver versus bone? So what about abnormal LFTs in MASLD? So ALT and AST can be elevated. However, it's usually less than 5 times the upper limit of normal. In other words, if you have a patient that you have with MASLD who comes with an ALT of like 500, 600, think of other causes which can be an overlap along with the MASLD. But most important, they can have normal ALTs. In fact, as you can see from this study, which had over 200 patients who actually had a liver biopsy, they showed that 37.5% had normal ALT, but had MASH or advanced fibrosis. In other words, if we just look at the ALT, you're going to miss over 30% of your patients who potentially have advanced fibrosis. And the flip side of it is 53% of those who had elevated ALT actually had no steatohepatitis and had no fibrosis. Well, this slide is a little frightening. This is the burden of MASLD kind of globally, and you can see whether you're talking about the US or Australia, our prevalence is over 30%. So we're talking about 3 to 4 out of 10 have MASLD. And certain areas like South America or the Mediterranean, it's close to 35 to 40%. I think the only continent where it's a little less, closer to the lower end of 20 is South Africa. And when you look at this is also kind of tells a story in itself. So back in 2015, stage 3 fibrosis, which was pre-cirrhosis, it was about 2 million. And we are predicting that by 2030, it's going to be 4.5 million. And similarly, in cirrhosis, back in 2015, it was 1.3 million, and we are predicting that by 2030, it's going to be 3.1 million. And what does that even mean? It means that we're going to see this huge increase in decompensated cirrhosis, increase in hepatocellular carcinoma, increase in liver-related adverse events and death, unless we do something. And this is not just in this country, whether you look at China or the Saudi Arabia, you can see these graphs are all very similar. It is also the most rapidly growing indication for liver transplant. And if you can see that in this first graph here, hepatitis C used to be the leading cause for people needing transplant. And then in 2012, we had these medications that got approved, which have completely changed the way we do hepatitis C and treat hepatitis C. And the patients who require a liver transplant with hepatitis C actually came down dramatically. Alcohol still remains the leading cause, but as you can see, Mazdut is right behind it. And that's actually a little bit of older data that we have. I think if we upgraded that, that gap is really much more narrower. And in fact, in women, Mazdut is the most common etiology for women needing a liver transplant. So this has really changed over the last 10 to 15 years. What about in our type 2 diabetics? Well, the way I look at it is, if you have a patient with type 2 diabetes and one more metabolic risk factor, they most likely have steatosis. They definitely have steatosis, and they most likely have steatohepatitis or fibrosis. So really to think about all of your diabetic patients, and when you look at this map, globally, 70% of your diabetics have hepatic steatosis. And that's why it's not surprising that all of the three groups, the ASLD, which is the American Association of Liver Disease, the EASL, which is the European, and the ADA, now recommend that all patients with type 2 diabetes should be screened for Mazdut and MASH. And just like when you see your type 2, you do the diabetic retinopathy, nephropathy, neuropathy, you should also now consider diabetic hepatopathy. Yes, there is a lot of ethnic disparities, as we can see from this study, which looked at more than 40,000 patients. 37% had Mazdut, just like we were expecting. And there has been an increased prevalence in pretty much all of the race ethnicities, especially the Mexican Americans. And could this be the diet? Could this be socioeconomic? Or could it be access to healthcare? Or could this be genetics? Now, there are two main gene mutations, especially the PNPLA3 and the MBOT7, which are seen in our Hispanic and the Asian population, which are more prevalent in these ethnic groups, and these increase your risk for hepatic steatosis, which is why we see a lot more severe hepatic steatosis in these ethnic groups. Whereas the last one, the HSD17B13, is actually a protective one. And this is more commonly seen in the Black population, and which is why, though we see more diabetes and obesity in our Black population, we actually see less fatty liver in that population. So just kind of going through steatotic liver disease itself. So this is kind of the umbrella term, and this includes a lot of this. And this is the other thing which I really like. This is made it very clear as to where your patient, which category your patient falls into. So yes, we have Mazdut at one end, which can then progress to MASH, and then we have MET-ALD. So MET-ALD is metabolic syndrome with alcohol. And how much alcohol? So if you have a female patient who drinks 20 to 50 grams of alcohol per day, and have metabolic syndrome, they fall into this category. Or if you have a male patient who has metabolic syndrome and drinks 30 to 60 grams, which I think is a lot, but they fall into this group again. So if they have less than 20 to 30 grams per day, they fall into the Mazdut. If they have more than 50 to 60 grams of alcohol per day, they fall into the alcohol-associated liver disease. So those in between fall into the MET-ALD category. Then, of course, we have the alcohol-associated liver disease, and then there are certain liver conditions that can be associated with steatosis, like hepatitis C, Wilson's disease, medications, methotrexate, tamoxifen, steroids. So where they have a specific etiology for the steatosis, and then a small group of patients who really fall into the cryptogenic, where we don't find an etiology. So thinking about the stages, like I said, this, again, I should update mine. The Mazdut should be more like 30 to 35% of the population now have it. And the good thing is about 80% still fall in that benign steatosis group. it is about 25% who then progress to steatohepatitis, which is this low-grade inflammation in the liver. And who are those patients who progress? Who are those 25 to 30% of the patients? They are the ones who have more than one metabolic risk factors. So if you have a patient who has, say, a BMI of 40 and diabetes, I can tell you with some surety that this patient likely has steatohepatitis. In fact, there was a study that showed that over a BMI of 40, they have an 80% risk of steatohepatitis and advanced liver fibrosis. Once you have NASH, you have a 25% risk of progression to cirrhosis. And of course, if you have cirrhosis, there's a 1 to 4% annual risk of hepatocellular carcinoma. But one point to remember here is that with MASLD and MASH, they are at a higher risk of HCC, even in the absence of cirrhosis. We do not have guidelines to screen these patients. As you know, we only screen patients with cirrhosis, and that's likely to change as we just see the burden of MASH increasing in our population. So my patient, let's see what he has. So could this be MASLD? Does he have steatosis? Yes, the ultrasound showed steatosis, and he has definitely more than one risk factors. So by definition, he does fall into, I think we can call this MASLD. Of course, we want to rule out other causes, and with that in mind, all of our patients, apart from having their LFTs, we want to look for the other metabolic risk factors. So A1C, lipid profile, thyroid test, check the hepatitis C and B. A lot of times we check our ferritin, and I can tell you this happens a lot. 30 to 40% of your patients with MASLD will actually have a slightly elevated ferritin. You don't have to go looking for hemochromatosis in this patient unless the ferritin is really high, it's over 1,000. So you can avoid checking the HFE gene mutations in these patients. The second thing that we commonly see is, excuse me, the ANA and the anti-smooth muscle. These can be positive in low titers in up to 40% of patients. So that's how common it is. So when do you then suspect that there could be an overlap between MASLD and autoimmune hepatitis? If your ALT is really high. So like I said, most patients, their ALT is less than 5 times the upper limit of normal. So if you have a patient with MASLD with an ALT of 500, then that's something else may be going on. So those are the patients that you may want to look for an overlap syndrome. So we identify this patient as having MASLD. So the next step is really risk stratification, which is, does this patient have fibrosis? Because it is the severity of fibrosis which is the main predictor of prognosis. So as you can see from here, the blue lines are those without fibrosis, and the yellow is those with fibrosis. And you can see the difference in their overall survival between those without fibrosis versus those with fibrosis. And the next graph here, we see that as the fibrosis stage increases, there's increase in the all-cause mortality, there's increase in the liver-related mortality. And it looks like the stage 2 is kind of the point where anything above stage 2, there's significant increase in an exponential way, the all-cause mortality and liver-related mortality. And the flip side is also very important to remember, that if there is improvement in the fibrosis, there's also improvement in the outcomes. And this was a study actually done among cirrhosis patients. And you can see the blue area there, those are the patients who actually had improvement in fibrosis. And you can see that their liver-related outcomes were so much better than those without any improvement. So how do we screen? So this really falls, I think the burden of this really falls on the primary care doctors, right? Because their primary care doctors are the ones who actually see all of these patients first. But anybody, whether it's the primary care endocrinologist, the surgeon, or the GYN who may have gotten a pelvic ultrasound and showed echogenic liver, I think the onus falls on all of us to identify those patients who are at a risk and then kind of evaluate them further. So step 1 is really identifying the patients, so anybody with risk factors or incidentally found to have steatosis on imaging or have elevated liver enzymes. The next step is some basic blood work, really check the CBC, check the LFTs, because that helps us to go to the next step, which is these non-invasive tests. And the one that's now recommended is the FIB-4. And we're going to talk a little bit about FIB-4, because this is really an important test that we can do at bedside when you're seeing your patients. And a low FIB4 indicates that the patient likely has no liver fibrosis, and those are the patients that actually can be followed by the primary care physicians. However, it's important that these be monitored, and we calculate the FIB4 every 2 to 3 years. Those with the FIB4, which is higher than 2.67, likely have cirrhosis. Those are the ones that should be referred to GI or hepatology. And of course, most of your patients are going to fall in the middle, right? So they're going to fall in the indeterminate risk. These are the patients, yes, absolutely, you can refer to hepatology, or if you have access to other tests like FibroScan or MR elastography, because they need a second test to evaluate or assess liver fibrosis. So we usually use the FibroScan in our clinics, and again, if the FibroScan is a low level, those can go back to the primary care doctors, and we have them just reassess in 2 years. Those with the FibroScan levels that are over 12 have cirrhosis, and we follow them. But again, there are some people who are going to fall in the middle. And here we use the third line, which is either MR elastography or a liver biopsy, or, which I actually encourage the patients a lot because this really helps them then, gets them motivated, is have them treat the metabolic parameters. So if you're dealing with uncontrolled diabetes or excess weight, if you can really be able to motivate them to lose some weight and get their blood sugar under control, you can actually push them now from the intermediate to the low risk group. And I think that really motivates them. So not everybody who falls in the middle actually needs a biopsy. In fact, most of them, we say, come back in 6 months, come back in a year, we'll reassess. So what is FIB4? I think all of you are very familiar with this. So FIB4 uses 4 parameters, right? The age, AST, ALT, and the platelet count. So you enter these numbers, you get a score, and like I mentioned, less than 1.3, these patients really have benign steatosis, can be monitored. Those above 2.67 are the ones that should come to us. But I think it's the intermediate group that we really should focus on. Because if we make some lifestyle changes here, these patients now can be pushed into the low risk group, and we can prevent them from progressing to cirrhosis. This can be used, there's an app on your cell phones which you can upload, or if you are the QR type kind of a person, that's the QR code for this. So my patient's FIB4 was 2.01, so he fell into the intermediate group. I'll skip that. This is the one thing I just wanted to just also point out. So the FIB4 has really not been studied in younger patients. So patients who are, your young individuals less than 35, think of a different modality like the ELF or the FibroScan. And the second aspect is those who are over 65, the cutoff for low fibrosis risk is actually increased to 2. So it's not 1.3, but 2. In other words, for the older individuals, you take a cutoff of 2 to call them as no advanced fibrosis. For advanced fibrosis, it still remains the same at 2.67. And this could probably prevent some of the referrals that we see. I have had patients who are 80 years old, FIB4 of 1.8. I think those patients can be monitored. So this is my patient. We went on to do an MR elastography. So that's the liver. I don't know if I have a pointer here. So that's the liver right here. This is your key here. So the liver should look like this. So this is no fibrosis, and this is cirrhosis. So you can see his liver is really all orange and yellow. So this was stage 4 fibrosis or cirrhosis. So a couple of other non-invasive tests that I thought I can talk about. One is the Enhanced Liver Fibrosis Score. Kind of was approved, I think, in this country last year, though it's been around in clinical trials for a long time. This uses biomarkers. Again, easy to do. This is available now. It looks at 3 biomarkers and gives you a score. So any score that's less than 7.7, these patients are unlikely to have advanced fibrosis. And those who are above 11, just like the FibroScan values, these are likely to have advanced fibrosis. And then you have the patients who are above 9 are likely to have some amount of fibrosis. So really, you want to identify those with a FIB4 of 9 and above. The FibroScan, again, I think a lot of you are kind of familiar with this, uses like an ultrasound-like technology to really measure the liver stiffness, and also we measure the CAP or the steatosis. So it really literally takes us like 10 minutes in the clinic. it has a huge patient, it's a huge patient satisfier, I think, because we see the patients do a FibroScan, we are able to tell them, hey, you have benign steatosis or you have you have some liver fibrosis, and we come up with a plan. And we do this, and once we do a FibroScan, and if they have some liver fibrosis, we actually do this every year to look for progression or regression. The only, problem with this is some patients, because of the body habitus, we may not be able to do a FibroScan, but for the most part, yes, we are able to do this at the bedside. And those who are unable to do a FibroScan, we usually offer them the MR elastography, which is an MRI-based test. Again, the patient should be able to get into the MRI machine, so no pacemaker, et cetera. It takes like literally 10 minutes, so it's not, yes, if you're claustrophobic, 10 minutes can also be a big deal, but it's still not the 30, 40-minute MRIs that most people are used to. And the other thing is it doesn't have a contrast, so you can actually use it in patients with CKD. So this is, again, a game changer for us, where we use the MRI to really risk stratify our patients with the fibrosis and steatosis. Again, you want the liver to look kind of blue. If it all looks red, that means it's more fibrosis. And the good thing is it also uses the MRI PDF and gives you a percent fat in the liver. Pretty much, if they, like I said, if they're able to get into an MRI machine, you should be able to do an MR elastography. The other thing that we use the MRI is actually to predict how they're going to be, where they're going to be in 4 or 5 years. So what we've seen that in patients with MASLD and who have no fibrosis, an increase in the in the liver stiffness by 1 kilopascal actually increases their risk of developing cirrhosis, 3 times higher risk of developing cirrhosis if there's a 1-degree increase in their kilopascal, which is why these patients with steatosis and fibrosis, we actually have them come back in a year and repeat the MRI. And in patients with already who have cirrhosis, an increase in 1 kilopascal in the liver stiffness predicts that 32% are more likely to have liver decompensation or death in 5 years, which means these are the patients, when you see this increase in kilopascal, you're going to predict, some sort of an outcome in 4 or 5 years. These are the ones that you're going to think about, should you be thinking about liver transplant earlier on, because you can kind of see where they're heading. So just a little blip about liver biopsies. Yes, we still do it in a small group of patients where these non-invasive tests are kind of putting them in the intermediate group, but clinically you're suspecting cirrhosis. Those are the group that we still do a biopsy. Or if, like I was explaining, if there's if you're concerned about an overlap, right? Steatosis along with autoimmune hepatitis or something else, we still do some liver biopsies here. It is invasive, there is pain involved in it, sampling variability. Remember, we get a tiny piece of the liver. In fact, the amount of liver tissue you get from a liver biopsy represents 1 in 50,000th part of your liver. So you can see how much of sample variability you could have. And more important, inter-observer variability. Even if you have 2 very experienced pathologists, there is some variability in how they report these, the slides. But yes, there is still a role, especially in clinical trials, where we still use biopsies. And so AI, out of scope for this talk, but AI is everywhere. And PathAI is kind of a global AI company which looks at histology. And this has really changed how we're looking at biopsies. For example, so this is how the biopsy now sees. You see the fat here, you see some inflammation here, you can see a couple of these ballooning hepatocytes here, because you need all of those 3 components to call it steatohepatitis, and you can see how easy it is to miss the inflammation and the ballooning hepatocytes. However, with AI, this is how it looks. So this is pretty remarkable. So again, it's just nicely color-coded. We see the inflammation, we see the ballooning hepatocytes, and it's very clear that this patient has steatohepatitis. Our patient did have a biopsy. We did not have AI, but you can clearly see the nodule formation and the cirrhosis. Coming to the treatment, I think early intervention is the key, and there's no way we hepatologists can even treat these patients if we don't work along with the primary care doctors and the endocrinologists. And the focus is, yes, weight loss, then certain dietary modifications like alcohol, and of course, treating all of the core metabolic parameters. So I cannot talk about treatment without talking about weight loss, right? So what we know is that even a little bit of weight loss goes a long way. So even if they are able to lose 3% of their body weight, the steatosis improves. If they're able to lose 5 to 8%, steatohepatitis improves, and if they're able to lose 10%, liver fibrosis is likely to improve. But this is not easy. From personal experience, I can tell you it is so difficult to lose weight, right? I mean, in fact, we've seen that only less than 10% of our patients are able to lose 10% of their weight in 1 year. So not easy, but does make a huge difference. And one of the common things that most patients ask is, about what are these diets available? Because there's so much available out there. And the way I look at it is that two things that you can do. You can either do macronutrient manipulation, that is, like as you can see, all of these different diets, you can see the three main macronutrients, how they are tailored to, and the timing manipulation, that is your intermittent fasting. The one diet that has been studied in Maslach is the Mediterranean diet. So what is the Mediterranean diet? Lots of vegetables, fruits, nuts, salmon, white meat, olive oil, less sugars, less red meat, less processed food. And then there is another thing called the green Mediterranean diet, which is more of the green vegetables and fruits and green tea. Yes, to me, this sounds like a great diet, but it might not apply to everybody. So there may be a little bit of adaptation to this diet might help when you're talking to your patients. And the Mediterranean diet has been associated with reduced steatosis, improved insulin sensitivity, and lowers the mortality by reducing the risk of cardiovascular death and diabetes. Now, patients with cirrhosis, what do they die of? Yes, we think about hepatocellular carcinoma and liver-related risk of mortality, but the commonest cause of death in patients with cirrhosis is cardiovascular. So we really want to hone it into that. So yes, we want to we do follow them for HCC, et cetera, but we really want to correct the cardiometabolic risk factors because that is their commonest reason for death. Intermittent fasting, a lot of my patients ask, here it is rather, when do you eat rather than what you eat? And there was a good study which kind of looked at about 6 studies with intermittent fasting in patients with Maslach, and they did find that those who were doing intermittent fasting had a reduction in their BMI, they had improvement in their AST/ALT, and improvement in their lipid profile. And it is safe in patients with MASLD, and there was some improvement in the steatosis also with this diet. Long-term data is still kind of pending, but I think it's a good, at least, starting point for patients to help them lose weight. Whereas the ketogenic diet, I'm not so sure about this diet. Yes, there was one study that actually showed that the keto diet did kind of overall reduce the inflammation in the body. So it's hypothesized that yes, so there may be some improvement in the inflammation in the liver, but I think some safety data is still needed here. Coffee. I always end my consult with coffee because it always kind of brings a happy end to this conversation. And the data is extremely strong here. It does improve steatosis and steatohepatitis, decreases the risk of progression to cirrhosis, decreases the mortality rate in patients with known cirrhosis, and decreases the rate of hepatocellular carcinoma in patients with known cirrhosis. So drink up, guys. How much? I'm not sure. But now we say about 3 cups. Initially we were saying 7 cups. That seemed a bit much. So now the dose of coffee is 3 cups, but it is this regular good coffee, not the frappuccinos. So a quick talk about this, because again, this is something that's very commonly asked. Our patients say, what about probiotics? What about prebiotics? So this was a study where what they did was they took the gut microbiome from an obese individual and put it in a mice. And those mice actually developed hepatic steatosis. But when that same gut microbiome from that same patient who loses weight was put in that mice, they did not develop steatosis. And that kind of brought up, with the last 40, 50 years, we have changed what we are eating. Our gut microbiome has changed. So has this also impacted, or has this contributed to the increased prevalence of MASH? And should we be targeting our gut microbiome as a potential preventive and therapeutic target here? In fact, this was a recently published study which showed that probiotics and prebiotics had a very positive effect in reducing the liver enzymes, lipid profile, and the inflammatory cytokines in patients with MASLD. So I think it's definitely something that is likely to help, but it's not going to harm. The other supplements not shown much benefit here. Talking about statins, as a hepatologist, I have begun to really love statins. So if there is an indication to start a statin, please consider starting statins. Elevated ALT and AST is not a reason not to put your patients on a statin if there is an indication for it. Statin has been associated in this particular study, which had nearly 8,000 patients, and 40% of these patients with MASLD were on a statin, and it showed that statins was associated with a 76% lower risk of all-cause mortality, nearly 62% liver-related mortality, and the statin was associated with lower risk of liver fibrosis progression. What we were not able to show is that statins improved fibrosis. So it did not improve fibrosis, but appears to prevent progression of fibrosis. So definitely something to consider in your patients. The other thing that they ask is about exercise. Absolutely, both aerobic and resistance exercise helps. Yes, we talk about 150 to 240 minutes per week. But of course, we want to tailor it to individual patients. It does not help to have exercise without any caloric restriction. And of course, once you stop exercising, you may lose that benefit. And really the only reason I put this figure up is I thought it was kind of interesting too, because a lot of our patients again ask, how many steps should I take, right? And I know we've gone over this whole thing, right? Was it 5,000? Was it 20,000? But it seems like based on this test, even as less as 3,000 to 5,000 steps per day seems to be helpful. And more important is what they showed was if there was a 1,000 step increment, it actually reduced your cardiovascular mortality by 15%. And if there was an increment of 5,000 steps, it reduced your cardiovascular mortality by 7%. So kind of thinking about my patients with NASH who have all of these cardiometabolic risk factors and at a risk of cardiac disease, I think this is kind of some important data. Alcohol. Most of my patients say, how much can I drink? And my quick answer is nothing, right? Because we know that metabolic syndrome and alcohol together exponentially increases their risk of fibrosis. And furthermore, we also know that patients who have metabolic syndrome and alcohol, their risk for HCC also increases. So really, there is no safe limit of alcohol in patients with MASLD. And if we are thinking about primary prevention of HCC, I think we have to have an approach where you want to treat the metabolic syndrome and you want to limit or abstain from alcohol. But easier said than done, but I think this is just important to say that there is really no safe alcohol in patients with MASLD. A quick thing about bariatric surgery, I'm not going to spend a lot of time, but as you can see from this study, patients who lost weight, this is 5 years post-surgery, they had an 84% MASH resolution. And of course, not surprising, the more weight loss, the more MASH resolution. And the reason I just wanted to put that up is that's what happened to my patient here. So CJ did undergo bariatric surgery, lost about 100 pounds, and you can see the dramatic improvement in his MR elastography. So this is the first one. You can see all of this red and yellow. This is fibrosis, and this is his MR elastography now. So he went from stage 4 to stage 0. And that was pretty remarkable. And in fact, I just did another one a couple of months ago, and his MRI looks very similar to the one in 2021 because he is able to maintain that weight loss. So just changing gears about medications. So the vitamin E and pioglitazone. So this was a study that I think was 10 years ago or so, looked at vitamin E versus placebo versus pioglitazone. And there was there was improvement in steatosis in both the vitamin E and the placebo and the pioglitazone group, but not much improvement in the fibrosis. So it appears to improve the steatosis, but not the liver fibrosis. However, in a small subset of patients, that is, those who did not have diabetes and those who did not have cirrhosis, there appears to be some improvement in steatohepatitis. So you may have a small group of patients that you could consider vitamin E and pioglitazone. Just a few things to remember about vitamin E. There is a possible all-cause mortality increase in patients on a higher risk of, higher dose of vitamin E. There is a slightly higher risk of hemorrhagic stroke with vitamin E. So I don't use it in patients who have uncontrolled hypertension, but it does seem to have a beneficial effect in preventing ischemic strokes. And there is a slightly increased prostate cancer risk. So again, I don't use it in men who are over 65. Pioglitazone, I don't use it often only because it causes weight gain, and that's kind of counterproductive to what we do when we talk about weight loss. However, if you have a patient whose BMI is normal and say has diabetes and has steatosis, I think this is a good drug. So these are some of the phase 3 drugs that are in clinical trials right now. Quickly going to go through all of this. I'm not sure how much time I have. So what is the FDA looking at? MASH resolution or improvement in the fibrosis, or both? So with that, of course, we'll start with semaglutide because everybody talks about semaglutide. This was the data from phase 2, and you can see that all the 3 doses resulted in resolution of MASH, which was very significant. However, there was not significant improvement in fibrosis. Now, the ongoing phase 3 trial data is a little bit better, so we just have to wait for the final outcome with semaglutide in patients with MASH. But what happens if you add a GIP to the GLP-1? You get tirzepatide, and here the results were pretty remarkable. As you can see, significant resolution in, so this is showing us MASH resolution. As you can see, there's significant improvement in with all the 3 doses, and there was an improvement in fibrosis. So this is really exciting data. Again, this is in a phase 3 study right now. What happens when you add glucagon receptor agonist to this? Well, you get retaglutide, and this is even more exciting. This data shows us improvement in fat, more than 30%, more than 50%, and more than 70%. So absolutely exciting data here, which we are looking forward for more data. Lanfibranor, the PPARs, again, shows some improvement in both the fibrosis and steatosis. And this was, I think, the most exciting, though. The FGF21 analogs, especially the efruxifermin, as you can see here, this one here shows improvement of 1 fibrosis stage. That is, patients go from stage 3 to stage 2. This is exciting, yes, 40 to 70%, but I think this is even more exciting. That is, 30% showed improvement in 2 levels of fibrosis. So those with stage 3 come back to stage 2 or less. I'm sorry, stage 1 or less. So 30% had improvement in 2 stages of fibrosis. So really exciting data that we're looking forward to seeing the end of these studies. Drum roll. Finally, we have the first FDA-approved drug, resmetirom. So resmetirom, this was the Maestro NASH phase 3 data here. So this is an oral drug once a day. And you can see from here, from the data here, improvement in the fibrosis and MASH resolution. So significant improvement in steatohepatitis, significant improvement in MASH, and in fibrosis. So this is exciting. And so how does this act? So the resmetirom is a thyroid hormone receptor beta agonist. So it really works on the thyroid receptors in the liver and the beta receptors. So it does not have any effect on the alpha receptor. So it does not affect those patients who are on Synthroid or who have hypothyroid. So this acts specifically on the beta receptors in the liver and reduces lipogenesis. So reduces the fat production in the liver. It acts on the beta, or reduces beta oxidation of fatty acids, thereby reducing lipotoxicity, it reduces the inflammation in your liver, reduces the oxidative stress, and thereby improves fibrosis. And it also reduces the VLDL production in the liver, and thereby reducing your plasma LDL and triglycerides. So this really is very liver-centric, and therefore you do not get the other side effects of any other, thyroid-related side effects. The only side effect that I have seen with this is actually diarrhea. So that can be, so I'm now kind of tell the patients up front, this is likely going to happen. So once they are aware, then they're less likely to stop the medication. So who are the patients that you are going to start? So this study is actually still ongoing. The FDA approved it early. It's an ongoing study. So right now, it has been approved only for patients with stage 2 and 3 fibrosis. So the first step is confirm that your patient has MASLD and doesn't have anything else, no other conditions that could explain the steatosis. Then you have to stage them either with your FIB4 FibroScan or MR elastography. Once you stage them and you know that they have stage 2 and 3 fibrosis and that you've ruled out cirrhosis, then you could consider treatment with resmetirom. So once you start, what are you going to do? Start the medication, bring them back in 3 months, mainly to look for any adverse effects, side effects, and see how they're doing. Then we bring them back in 6 months. And we do assess using a FibroScan or MR elastography here to see if there's any response to treatment. If there is no response to treatment, don't stop. This is still too early, but it's good to know if they have an early response, but these are the ones who are going to fall into that 30 to 40% where you can expect them to have fibrosis improvement. So we do assess them at 6 months, but don't stop the treatment if you don't see any benefit. Bring them back in a year. In a year, if there's worsening of fibrosis, obviously, yes, you're going to stop it. If there is no change, you could opt to continue because, again, this is such early data, we don't know how long it might actually take to improve fibrosis. So if they are tolerating it, you can continue the medication, or you could, hopefully by then we'll have these other newer medications that get approved, so maybe we could change the way we treat. And of course, if there's improvement, we are going to continue. And what is improvement? If there is, the ALT drops by at least 17 points, or if it normalizes, or by either the FibroScan or MR elastography, there is a 30% improvement in the steatosis or fibrosis. That is a positive outcome, and those patients we then continue. The one question that some of the patients ask is, do I have to be on this lifelong? And my answer is, I actually don't know, right? But I'm anticipating that if your steatohepatitis has resolved, if your fibrosis has resolved, then I think we can get these patients off the medications and monitor them. But again, very early, but this is exciting. We have patients on it, and so far, in our small group of patients, all of them have tolerated it. We've not stopped medications on anyone so far. So to summarize, AAA, awareness of MASLD, use those algorithms, they're very well defined now, and then take advantage of these evidence-based treatment options. And a little plug here, we do have clinical trials that we are running at Virginia Mason, so if you feel that you have a patient that you want to put in a clinical trial, happy to evaluate them. Thank you. And I'm sorry if I overshot the time. Oh, perfect. Yes.
For stage 4 fibrosis, if someone loses weight, is it reversible?
Yes. I showed you a more, patient who actually had bariatric surgery, but I have seen patients who, and one caveat to this, if they have cirrhosis without portal hypertension, absolutely we have seen some remarkable improvement. Once they develop portal hypertension, I think that's still debatable whether they have improvement. Yes.
Like negative reasons, but I was wondering if the recent data for aspirin and triglycerides have been convincing enough for you to recommend it?
That's a great question, and I kind of always wonder if we are going to be treating MASLD like our cardiologists treat coronary artery disease, whether we're going to put them on aspirin, whether we're going to put them on a statin, and then put them on semaglutide. And we may be getting there, but the data with aspirin is not very strong, so we don't really recommend unless there's other reasons for them to be on aspirin. Yes, sir.
Your diagnosis steatosis, when do you do an autoimmune workup to rule that out?
That's a good question because it's not uncommon to have ANA and anti-smooth muscle being positive in these patients too. I think about other overlap syndromes if their LFTs don't match what I expect. What I mean is that if your ALT and AST is just mildly elevated and their ANA and anti-smooth muscle is positive, you don't have to worry about overlap. But if their ALT is significantly elevated, so we take over 5 of the upper limit of normal, then there is likely to be some overlap. So if your ALT, if you have your patient with an ALT of 500 with steatosis, that does not explain just steatosis alone. That means there is some overlap. Yes.
For our anxious patients who want to get a vital scan every 6 months or a year, it's not necessary. How soon do you see changes in weight loss?
So the question is, how soon do you see a weight loss, and how do you convince patients to get FibroScans? Earlier we were depending solely on FibroScans, but I'm actually using that ELF test a lot more. It's more easier to do, especially in our outreach clinics and where we don't have FibroScans. So I'm actually using ELF instead of a FibroScan or MR elastography. And patients are also more likely to get a blood test rather than coming to Seattle or somewhere else to get these tests. How often do I do it? I do it every year. And improvement is pretty remarkable. If they lose weight, we see that kind of improvement kind of coinciding with their weight loss. Yes.
Could you say that ALT doesn't really correlate with severity of disease, and that a lot of people have disease without an elevated, it doesn't seem like a very good discriminator between progressive disease and doesn't. Yet at the end you said they should screen with ALT and AST, and if you look for improvement, that's the marker of improvement when we're treating it.
That is a good question. If the ALT is elevated, then it helps to monitor that, right? So then we can look for improvement in ALT. But you're absolutely right. About 30 to 40% actually have near normal ALTs. In that, we do depend upon FibroScans or MR elastographies or ELF test. How do you identify? I think we should identify the at-risk patients based on their risk factors. We should not look at their ALTs. So if you look at the ALTs, you will be missing a lot of your patients. Yes. When you look at the definition, right, you need steatosis and one of the risk factors to define it. So how do we know if the patient has steatosis? A lot of times by imaging. So in that sense, yes, we do get ultrasound to look to see if they have steatosis in your patients, say with diabetes or high blood pressure, who have normal ALT. So I think there is a role of ultrasound. But by definition, you don't need any imaging, right? So, but if you know they have steatosis in some other ways, or maybe the surgeon who took out the gallbladder told you that the liver looked fatty, that patient actually does not need imaging because you have some way of assessing that they have steatosis. So we do ultrasounds because most patients, we don't know if they have steatosis unless we have some form of imaging, so we do the ultrasounds. But if you see your patient in clinic who you kind of have one of these risk factors, I think it's just helpful to do the FIB-4, right? If the FIB-4 is low, you can just monitor them. If the FIB-4 is high, then I think it does, you do need to go the next step.
So for type 2 diabetes, you mentioned that they should be screened from MESO. So how do you do the screening? FIB-4 or FibroScan?
Yeah, I think that's the easiest way to get this to see the patient diabetes.
Thank you so much. I really appreciate this.
Stretch, get food, come back at 8:30.